Good afternoon. Hi. Thank you for joining us today. My name is Lori Smetanka, and we are glad to have you with us this afternoon to talk about a new reimbursement system that CMS has put into effect for skilled nursing facilities beginning October 1st of 2019. It's called the Patient-Driven Payment Model. And we are delighted to have here today Toby Edelman, who is the Senior Policy Attorney for the Center for Medicare Advocacy, who is going to walk us through the PDPM program, that model, and then we're going to talk about what it could mean for residents and what we're already seeing. So I'm going to turn it over to Toby in just a minute. I just want to give you some housekeeping items. First of all, this webinar is being recorded. Also, if you have questions, please type them into the question control panel in front of you. You can mark in any questions, and we'll get to as many as we can, either throughout or at the end of the program. Also, the link to the PowerPoint that Toby is going to be going through today is in the chat box. You can download it from there. We'll also send it out after the webinar. And also, we will send out the recording and the materials after the webinar as well. So thank you so much for joining us. And Toby, thanks for being with us today, and I will turn it over to you.
Okay, thank you, Lori. It's good to be here to talk about this new reimbursement system that the Centers for Medicare and Medicaid Services implemented October 1st, as Lori said. Next slide, please. So what I want to do at the beginning is talk for a few moments, next slide, please, a few moments about what is required for coverage under Medicare Part A for a stay in a skilled nursing facility. But primarily what I want to do this afternoon is focus on the patient-driven payment model and what its impact is already on therapy, certainly, but also admissions, assessment, care practices, transfer and discharge, and other issues. So even though it's about a reimbursement system, it's really affecting the residents that we care about. Next slide, please. So the basic requirements for a Part A stay under traditional Medicare are, first, a 3-day qualifying inpatient hospital stay. The person must be called an inpatient, and people might know about the issue of observation status when they're called outpatients. But residents or Medicare beneficiaries need to be inpatients in the hospital. The Medicare program counts days by midnights, not 24-hour periods. So our shorthand stay for a 3-day qualifying stay is 3 midnights. The person needs to go to the hospital, to the skilled nursing facility generally within 30 days of discharge from the hospital. Physician has to certify the need for SNF care, and this is critical. The person must need daily skilled nursing or rehabilitation services. Now, in the regulations, daily for nursing is 7 days a week. For rehabilitation, it's 5 days a week, or it could be a combination of the two. 3 days of rehabilitation and the other 4 days of nursing, but it needs to be daily skilled services. As a practical matter, the person needs to get these services on an inpatient basis. Next slide, please. I want to talk a moment about Jimmo versus Sebelius. This is a nationwide class action lawsuit that our office, the Center for Medicare Advocacy, litigated with Vermont Legal Aid in Vermont. And it was intended to eliminate the improvement standards, not only in skilled nursing facilities, but also in home health and outpatient therapy. Although the rules and the statute for years have said people don't need to be improving in order to qualify for Medicare coverage in any of those settings, the urban myth, or the myth of the world, was that people had to be improving, and if they plateaued, then Medicare would no longer pay. So we filed this nationwide class action, and what we did that was a little bit unusual is we sued on behalf of not only individuals representing a nationwide class, but also the 6 organizations that are listed, showing that this really has an impact, this myth of improvement has an impact on people with chronic conditions. Because if somebody has MS, MS is certainly not going away, but it doesn't mean that the person doesn't need skilled care. So we filed the lawsuit in 2011, survived the motion to dismiss by the government, settled it in 2012, and the court approved the settlement in January 2013, now 7 years. Sort of amazing. And what the settlement says is that Medicare covers care and services in each of these settings if the Medicare beneficiary is expected to improve, of course, but also if the person needs professional nursing or professional therapy services to maintain function or to prevent or slow decline or deterioration. Next slide, please. We continue to get calls from across the country and in all of the care settings covered by JMO. Still hearing the same things. Patient is plateaued, the patient is stable, the patient has chronic condition. So we went back to court and got additional relief from the judge ordered in 2017. You can see the things that Judge Rice ordered CMS to do. Next slide, please. And so the most important thing at this point is to go to the JMO homepage because there's an important message box that sets out the correct standards, the maintenance standard of care, links to resources, and frequently asked questions. And what we suggest to people when they're arguing about JMO is to use the transmittal version of the revisions to the Medicare Benefit Policy Manual. That's because in the revisions version, all of the changes made by JMO are in red italics. So it's very clear when the providers say, well, the regulations didn't change, the law didn't change, so we didn't have to do anything different. The point is, yes, there were changes, but it was in practice, not in your practices, not in the requirements of law. This is not a new standard, but it's got to be crystal clear to you now in the red italics. So that's JMO, and that's still important as we go forward in the new reimbursement system because JMO is still good law. Although we just got an email message from somebody this morning saying the facility said, oh no, that's old, that's a few years old, doesn't count anymore. Yes, it does. It really does matter. Next page, please. Next slide. So now we're going to focus the rest of the time on the patient-driven payment model. It was effective, as we said, October 1st of last year, and it was supposed to be budget neutral, replacing the resource utilization group system that had been in place for about 20 years, almost 20 years. In theory, what PDPM does is base payment on resident characteristics rather than on services provided. And I think that'll be a little bit clearer in a moment what I mean by that. Next slide. The new reimbursement system makes enormous changes in the financial incentives for facilities. Very, very different from the prior system, resource utilization groups. So we will be discussing what these incentives have done. Clearly, and we knew therapy was going to be changed, but we are also hearing, we also have concerns about admissions and assessment practices and transfer and discharge. All of these things are changing to reflect the financial incentives. Next slide, please. So the new system reflects a reaction to the RUG system that was, as I said, in place for about 20 years. So I want to talk a little bit about RUG so you can see what happened and what was changed. In the RUG system, there were two case mix adjusted categories, nursing, which include nurse staffing, and also non-therapy ancillaries, and that generally means drugs, medications that residents get. And then there's rehabilitation. Now, under the RUG system, the more minutes of therapy a resident received a day, the higher the reimbursement rate for the facilities. So even though it's supposed to be case mix and prospective, it really was paying for facilities on the number of minutes of therapy provided. Next slide, please. So there was a perception, a widespread perception, that there was an overuse of therapy. Now, we were still concerned about the lack of JMO maintenance therapy under RUGs, but there was a perception that facilities were providing too much therapy to residents. Whether they were actually providing the therapy or just billing for therapy is a question, but this was common view, too much therapy. So under RUGs 4, by the time the RUG system came to an end, more than 90% of residents were qualifying for a Medicare Part A stay because they were getting rehabilitation. And in fiscal year 2017, 60% of the claims, for 60% of them, SNFs were billing at the top 3 highest of the 66 categories. So clearly facilities were billing for reimbursement and billing at the very highest levels. The Inspector General and the Medicare Payment Advisory Commission were both reporting that RUGs encouraged excessive therapy and were underpaying non-therapy ancillaries, not paying enough for the drugs. And MedPAC was reporting very, very large profit for facilities under RUGs. There was a lot of litigation also under the False Claims Act, particularly against some of the large nursing home chains for overbilling, billing everybody at the highest categories of RUGs, and also for fraudulent billing for services that were not even provided at all, let alone appropriately at some high category. Next slide, please. So what PDPM did was overcompensate for concerns about RUGs. And we'll talk about this later, but CMS says very explicitly that under PDPM, it will pay less reimbursement for residents who receive any therapy at all, and more for residents who receive no therapy. They're very explicit about that. Now, this is very significant because, as we said, in order to qualify for Medicare Part A coverage in a skilled nursing facility, the beneficiary needs either rehabilitation services 5 days a week or skilled nursing services 7 days a week. So if we're going to be cutting therapy, that's going to affect people's eligibility for Medicare coverage of their stay. Next slide, please. So I just want to go through very quickly how PDPM works. So instead of the two case mix categories that RUGs have, nursing and rehabilitation, PDPM has 6 federal-based payment rates. 5 of them have case mix adjustments: physical therapy, occupational therapy, speech-language pathology, nursing, and non-therapy ancillaries. So nursing is divided into nursing and drugs, and the 3 therapies are separate. They're all separated out from each other, and one component is not case mix adjusted. Next slide, please. For each of the 5 case mix adjusted components, PT, OT, speech, nursing, and drugs, there are a number of case mix groups. So PT has 16 groups, OT has 16, speech language pathology has 18, nursing has 25, and drugs has 6. Next slide, please. So what CMS next does is separately calculate the case mix component by multiplying the case mix index by the component federal-based payment rate, whatever that's supposed to mean. But it's a separate calculation for each of the 5. Next slide, please. The next thing CMS does is apply a variable per-day adjustment schedule. What that means is that there is automatically a reduction in the daily payment for 3 of the case mix categories on an automatic sliding scale. So for physical therapy and occupational therapy, after day 20, the rate goes down 2% every 7 days. So there's a decline in the payment under this variable per day adjustment. There's no new assessment, it's just an automatic decline under the schedule. Non-therapy ancillaries decline 3% starting on day 4 of the Part A stay. The 2 case mix components that don't have any adjustment, they stay at whatever rate they were based on the original assessment, are nursing and speech. Those 2 stay the same. Next slide, please. And then finally, CMS adds these 5 case mix adjusted components to the non-case mix adjusted component, and it comes up with the total daily rate for each resident. Now, one of CMS goals for the new reimbursement system was to simplify the RUG system. That obviously didn't happen. PDPM is much more complex than RUGs ever was, and has many more possibilities. It's thousands of possibilities if you put all these different components together. RUGs at the end had 66 possibilities. Next slide, please. PDPM also changes the mode of therapy. Under RUGs, 99% of therapy was billed as individual therapy. Now that's sort of interesting to say that because until just about the end, until the Obama administration, facilities could have a group and then bill, say, 4 residents and bill 100% of the therapist time to each of the 4 residents. That would give a lot of minutes to each resident. The Obama administration said, no, we're not going to allow you to bill 400% of one resident's time. You could have to divide up the therapist time among the residents in the group, so 25% each, not 100% each. And so lo and behold, then what we got was facilities reporting, oh, we're doing individual therapy now. So at the end of RUGS 4, 99% of therapy was billed as individual therapy. PDPM allows up to 25% of therapy in each type of therapy to be provided in group or concurrent settings. Group is several residents, now from the 2019 regulations, 6 residents doing the same kind of therapy. Concurrent means more than one resident doing different things. But the PDPM is allowing 25% of therapy to be provided in these different ways, doesn't have to be individual, although their expectation still is that most therapy should be individual. That's the better way of providing therapy. What CMS says is if a facility exceeds the 25% cap, it will get a non-fatal warning edit, which means there will be no consequence, certainly no financial consequence to the facility, at least now. Maybe sometime down the road it will change the regulations, but for now, there is no consequence to the facility for having more of the residents in group or concurrent therapy.
Toby, one question that just came in is kind of a foundational question. PDPM applies to residents using their Part A SNF benefit. That's what it focuses on, right?
In traditional Medicare. This is not Medicare Advantage. This is traditional Medicare.
Thank you.
Okay, next slide, please. Interim payment assessment. What PDPM says is that if the resident really changes quite a bit from the original assessment, which is the 5-day assessment under PDPM, then the facility can do a new interim payment assessment. The final regulations in August 2018, in one of the very few changes that were from the proposed rules, did not include any criteria for IPA. So we don't really know how that will be used at all. What they had originally proposed is that if the resident was not expected to return to the original clinical status within 14 days, then the facility could do an interim payment assessment. But the final rules don't have that standard, and so we don't really know what that means or how it's being applied. Next slide, please. CMS did something that I think was quite unusual in the final rules. I don't remember seeing anything like this before, but it included 2 tables that illustrate the impact of PDPM's changes on residents and on facilities. There's one called Impact Analysis on Residents. One is called Impact Analysis on Facilities. So they're saying which residents would bring in a higher reimbursement rate compared to what it would have been under RUGS, and which residents will bring a lower reimbursement rate compared to what they would have brought under RUGS. Next slide, please. So the preamble talks about this. It says, well, if the resident has high drug costs, needs extensive services, is eligible for both Medicare and Medicaid, needs IV medication, has end-stage renal disease, diabetes, or wound infection, amputation or prosthesis care, or a very long prior inpatient stay, that's who will get a higher rate. Next slide, please. And they even wrote, we project that for residents whose most common therapy level is RU, ultra-high therapy, the highest therapy level, there would be a reduction in associated payments of 8.4%, while payments for residents currently classified as non-rehabilitation would increase by 50.5%, an enormous increase. There it is, in the language of the preamble to the final regulations. Next slide, please. I think the tables, though, the tables that I think are so unique, show to me even more starkly which residents are going to get a higher reimbursement rate. Male, under age 65, if they stay in the skilled nursing facility for 15 days or fewer. Now, you know, under Medicare Part A, the large copayment begins day 21. And so traditionally, we've heard people getting a 20-day stay. PDPM says, no, we're going to reduce that general length of stay to 15 days or fewer. If the person was in the hospital for a very long time, if the person didn't get any therapy in the skilled nursing facility, is severely cognitively impaired and needs a ventilator. That's who's going to bring in the most money. So really, if there's a young man under 65 who was in the hospital for a month and stays in the skilled nursing facility for 10 days and doesn't get any therapy and needs a ventilator, that's going to be a really high rate. That's who's most desirable under the RUG system. Next slide, please. So who gets a lower rate? Well, females, residents over age 90, residents who stay in a Medicare-covered stay for 31 days or more, if they had a very the shortest permissible 3-day inpatient stay that qualifies for Medicare coverage, so just having a 3-day stay. If the person gets all 3 types of therapy, which was common under RUGs, people would get all those therapies, get a lot of minutes, get a high rate. Now if they get those therapies, they're going to get a lower rate. If they're only mildly or moderately cognitively impaired, or if they're cognitively intact, and if they don't need a ventilator or infection isolation. Those are the residents that will bring in lower rates under PDPM than under RUGs. Next slide, please. So the next question is, what does CMS say about the impact on facilities? What they say in the preamble, if there's a high proportion of non-rehabilitation residents, if they're small, nonprofit, government-owned, hospital-based, and swing bed, they should do better under PDPM. Next slide, please. But then the tables make it very, very stark. Which part of the country will get higher reimbursement rates? If a large proportion are dually eligible residents, if very few residents get Medicare coverage, stay for the full 100 days in the benefit period, and if most of them are billed, most of the covered stays are billed as non-rehabilitation. Next slide, please. So the lower rate is for urban mid-Atlantic facilities when there are 25% or fewer of the residents who are dually eligible for both Medicare and Medicaid. If as few as 25% or as small as 25% up to 100% are 100 days, and if 0 to 10% of the stays are billed as non-rehabilitation. If they're billing few stays as non-rehabilitation, their rates are going to get lower. Next slide, please. So obviously, seeing this Federal Register, and actually I was on the 4 technical expert panels that were supposedly leading to this, because you get to nominate yourself if you want. So I was on those. We were very concerned. I was very concerned about what was going to happen to therapy under PDPM. That just seemed like the most extreme thing that was going to change quite dramatically. Would beneficiaries who needed therapy even get admitted to skilled nursing facilities? Would they get therapy? Would they get individual therapy? What would happen to the maintenance therapy under JMO? Would that even be at all possible anymore? I know in our comments we were on the proposed change to the reimbursement system. We wrote about JMO. CMS's comment in the preamble is, no, we don't have to do anything special about JMO. It doesn't really make a difference. Next slide. So, okay, we were worried, and then what happened? On the first day of the effective date of PDPM, October 1st, the impact was immediate. Thousands of therapists lost their job nationwide, and we know that. I mean, it was in the trade journals, October 2nd, how many therapists were losing their jobs. All of the therapy associations, physical therapy, occupational therapy, speech-language pathology, were all just alarmed by the number of their members who had lost their jobs or been put on an as-needed basis. They no longer had full-time jobs. They were being told to use group and concurrent therapy instead of individual therapy. Genesis Healthcare acknowledged that it laid off 585 therapists, about 6% of their rehabilitation employees, October 1st, although they've sort of walked that back a little bit and said maybe it was closer to 500. But still, we have thousands of therapists losing their jobs. And I think as much as we knew that there were going to be significant changes in therapy, the speed, to me, was totally shocking, and I thought the behavior of facilities was extremely brazen, just to lay off people so rapidly without realizing that that's still an important eligibility requirement for Medicare beneficiaries. So that was quite shocking. Next slide, please. Now, the important point is that PDPM did not change the eligibility and coverage rules. People still qualify for a Part A stay if they need therapy 5 days a week or skilled nursing 7 days a week. And we know that therapy is supposed to be provided as it's assessed and as it's ordered in the care plan. Facilities can't just ignore the care plan. Care plan says individual therapy. They can't suddenly have group therapy or concurrent therapy. That's not appropriate. Whatever's in the care plan is what's supposed to happen. We also started thinking that the baseline care plan was probably going to be more important than ever. And this is one of the changes that was made in the revised requirements of participation in 2016, the requirement for a baseline care plan. Now, the regular care plan doesn't have to be done for 21 days after admission. Well, baseline care plan has to be developed within 48 hours of admission, and it explicitly includes therapy. So it's going to be especially important that the baseline care plan be developed and implemented because the length of stay is so reduced they may never get to the 21 days for the regular care plan. Next slide, please. So what should people do if they're concerned about the therapy, if the SNF is changing the amount or the type of therapy that a resident is receiving? Well, one thing to do is to say to the facility, we want to have a care planning meeting. What's going on here? Medicare eligibility and coverage haven't changed. You're supposed to give me therapy as assessed and ordered in the care plan. Why are you changing things? Next slide, please. We have some very useful language in the preamble to the final regulations in August 2018. Where CMS said, we believe individual therapy is usually the best mode of therapy provision as it permits the greatest degree of interaction between the resident and the therapist and should therefore represent at a minimum the majority of therapy provided to the resident. All group and concurrent therapies should be well documented in a specific way to demonstrate why they are the most appropriate mode for the resident and reasonable and necessary for his or her individual condition. Now, these are just a few of the statements that are made, but if you look around those pages in volume 83, around page 39,239, there are a lot of similar statements in the preamble around that section of the preamble about why individual therapy is appropriate, probably most appropriate for most people, and why facilities would have to document anything other than that. So that's important language. Next slide, please. They reiterated this, CMS, in the 2019 regulations, where they said groups could be up to 6 people. They said SNF should include in the patient's plan of care an explicit justification for the use of group rather than individual concurrent therapy. The description of care plan should identify the specific benefits to that particular patient of including the documented type and amount of group therapy. Again, around that page, 38,726 in the August 7th, 2019 Federal Register, there's a lot of language that's similar about the importance of individual therapy and the facility doing what the resident needs, documenting why group therapy would be appropriate. Next slide, please. CMS also put out frequently asked questions for the new reimbursement system, and question number 12.1 from August, PDPM does not change the care needs of SNF patients, which should be the primary driver of care decisions, including the type, duration, and intensity of skilled therapies made on behalf of SNF patients. So they make the same point over and over again. We need to hold facilities' feet to the fire and say, this is what CMS says, why are you changing things? Next slide, please. So maybe this hasn't happened to, one of your clients or somebody you're working with, or you haven't heard that, but people are still concerned, or maybe they don't like the facility response, or if they think it might be a little bit safer to do this together as opposed to individually, whatever. There are some other things that we think maybe could be tried. Maybe talk about this at a resident council meeting. There's some safety in numbers there. Talk about what's going on in therapy in our facility. Why is it changing? And people could file a grievance with the nursing facility. That's another new requirement from the 2016 requirements of participation. Now, the administration has proposed last summer a dramatic change to the grievance process, but those changes haven't been made final. So for now, at least, we do have a grievance process, and people can either orally in writing file a grievance with the official grievance officer who is supposed to respond to it in writing. It's a good process. That's a good regulation. Do that. You could try to file a grievance with the facility. We think maybe people could file a complaint with the state survey agency. Maybe the state survey agency would have some interest, although they're not interested in reimbursement, but if they hear that people are not getting the services and care plans, they might be interested in looking into that complaint of assessment and care planning. Possibly we could talk to the regional offices or central office of CMS. Now, CMS added a new items to the discharge assessment to keep track of the minutes of therapy and the type of therapy people are getting. They claim they could monitor that decline in therapy. We could be encouraging them to do that and let them know that we're hearing problems, if we are hearing problems in therapy, and ask them to monitor closely what's going on with therapy in individual facilities. And I think people can also let their members of Congress know that they're not getting the services they need that are in their care plans. Okay, next slide, please. So what about concerns that we might have beyond therapy? Obviously, there are other things going on. Therapy seemed to be the most obvious, immediate problem, but other things are also happening. So next slide, please. The first is admissions. What's going on in admissions? I've seen articles suggesting that nursing homes may now start specializing in new areas, such as ventilator care and dialysis. Now, residents, we know that residents who use ventilators had a very, very hard time getting a nursing home bed. Most nursing homes would not take people who needed ventilators at all. In fact, that's why people went to long-term care hospitals. That's where most ventilator care was occurring. But now we have been hearing that facilities are actively recruiting people who need ventilators. I'm actually concerned about this issue. I was at a ombudsman training in Illinois, and a local ombudsman told me that one of the worst facilities that she visited on a regular basis, the residents told her they were being moved from the second floor because that was going to be a new ventilator unit. So she was alarmed because this was not a good quality facility. And I came back to D.C., and 2 days later, I saw a press release from the facility that said, "Great announcement, we're opening a ventilator unit." And I looked up the facility, and it turns out it's a candidate for a special focus facility. So, that is by definition one of the most poorly performing facilities in the country, according to CMS and the state that put it on the list, and that's who's recruiting ventilators. So I got pretty alarmed about that. Next slide, please. So why are facilities so interested in ventilators? Why are they recruiting them? Well, Skilled Nursing News, which is a relatively new online newsletter, wrote an article in the summer called "Respiratory Therapy's Massive Skilled Nursing Opportunity under PDPM," or Respiratory Therapies Opportunity. And it gave several reasons why ventilators were such a good option for facilities. The first was that a resident with a ventilator would be put in the highest case mix group for the nursing component of the stay. Now, as I said before, that is one of the two, the nursing and speech-language pathology, that don't decline over time with the variable per-day adjustment. So once the person is assessed in the 5-day assessment as being in that highest category, however long the resident stays, that component would stay at the highest level. The second thing they said in the article is that a person on a ventilator has a greater chance of using 100 days of Medicare coverage. The third point was that all that would really be necessary is maybe 15 minutes of time for either a therapist or a nurse with a resident who had a ventilator. So it's not a big additional staffing burden, but the upside is that facility could get as much as $1,200 to $1,800 extra reimbursement per week for a resident on a ventilator. So that was skilled nursing news in July. Next slide, please. An analysis by this organization, Zimmet Healthcare Services Group, of the first 6 weeks, so this was mid-November of PDPM, said that they were surprised that they had not expected the special care high group to be so well represented. That was respiratory therapy. It generated well-deserved attention, with several high-profile service providers marketing respiratory therapy's potential return on investment. So facilities got the message, and they started recruiting people who are using ventilators. It's financially quite advantageous, and they're making a lot of money. Next slide, please. But I'm concerned not only because the examples I heard, obviously just anecdotal at that point, but I did hear about poor quality facilities, or the ones, or two, these two examples of poor quality facilities recruiting residents with ventilators. I think we are also concerned because we've heard about very serious problems of infections, especially residents who use ventilators. Next slide, please. The New York Times had an article September 11th, so just before the new reimbursement system went into effect. Nursing homes are a breeding ground for a fatal fungus, about drug-resistant infections that were very prevalent in residents using ventilators because of the low staffing levels and poor infection control practices. This is a very alarming article. People going to the hospital, infecting people in the hospital, these funguses that do not respond to anything, any drugs that we have. And it was primarily the people in nursing homes using ventilators. So I was alarmed seeing, here's the financial advantage, here are facilities that are poor quality, trying to get ventilator people. They're probably the last facilities that should be taking on ventilators. So I got extremely concerned about that. Next slide. Another service that brings high reimbursement to residents is dialysis. Another skilled nursing news article in November, so just a couple of months ago, nursing home dialysis demand drives post-PDM push to specialty services. It described dialysis as home dialysis, but done in the nursing home, as a major growth area for nursing homes, both financially and clinically. And it highlighted two nursing homes that were really focusing on dialysis. I looked up both facilities. One is a one-star facility, so it's much below average. The second is a three-star facility, but only because its five-star quality measure rating, its self-reported quality measure rating, boosted the two-star that it got in health surveys, to below average in health surveys, to 3 stars. So it became average because it self-reported very good quality measures. Not the best type of facility to be doing dialysis. Next slide, please. So the concern is that facilities should not be taking on new categories of residents without doing an update on their facility assessment. Facility assessment is the third new change in the revised requirements of participation in 2016. And what it says is if a skilled nursing facility, or this is what I'm saying, that's not what the facility assessment says, but if a facility is adding a new type of service, it's required to do a facility assessment. The purpose of these facility assessments is to determine what resources are necessary to care for residents competently during day-to-day operations and emergencies. Assessments are supposed to address the resident population, and facility resources. And facility resources is defined to include equipment, services, and staff. Next slide, please. So the assessment, which is done annually, has to be updated if there is a substantial modification to any part of the assessment. The State Operations Manual, Appendix PP, that explains what these standards mean, gives 2 examples of modifications that would require an updating of the annual facility assessment. Admitting residents who had not been admitted before. 2 examples, residents with ventilators and residents who are having dialysis in the facility, or having dialysis at all. So that seems to me that CMS has acknowledged this is a significant change. The facility has to show that it has updated its assessment, it has enough staff, it has enough equipment, it is ready to provide care to these new categories of residents it hasn't had before. Next slide, please. So I decided to look at the deficiencies for facility assessment, F838, from 2018 to the present. Oh, excuse me, I jumped a slide here. So this slide says what that F-tag says, that the facilities are encouraged, but not required, to seek input from the resident, family council, residents, their representatives, or families about the facility assessment. So they should be, or they could be, they're encouraged to reach out to us about the assessment. I think we could ask for a copy of it. I think it's unlikely that the facility will give it to us, but it might be worth asking. They certainly should be asking residents and their advocates, their representatives, their families, about what they think should be in the facility assessment. Next slide, please. We know surveyors can see the assessment, and we're asking, actually, I did ask CMS, Survey and Certification Office, to put out a survey and certification letter to the state survey agencies to remind them of this authority to look at the facility assessment and the importance of doing so because of PDPM. I was sort of brushed off about that, but I think we're going to write a formal official request. People are interested in that, saying, okay, CMS, we know from PDPM that facilities are taking on people they haven't had before. We just want to make sure that they have enough staff and they have the equipment and they're ready to do it. So I looked up the deficiencies for the facility assessment requirement. 631 facilities have been cited with a deficiency from 2018 to the present. Now, like most deficiencies, we know almost everything is called either no harm, DEF, or substantial compliance, BC. But there were 10 facilities that were cited with harm or immediate jeopardy, and I looked at the jeopardy deficiencies. Next slide, please. One of them was a facility in West Virginia from a survey November 15th, 2018, Morgantown Health and Rehabilitation Center. That facility was cited with 14 deficiencies, including 4 jeopardy level deficiencies for resident preference for care, nurse competency, facility assessment, and quality assurance. And the assessment deficiency was based on the fact that the staff had not been trained and they were not competent in providing IV therapy via PICC lines to residents who had PICC lines, and they had residents with PICC lines. So that facility was cited with those 14 deficiencies, including the 4 jeopardy deficiencies, and a civil money penalty of over $300,000 was imposed. So this facility assessment, along with the other problems, can be an important requirement for facilities to make sure if they're taking on new people, new kinds of residents, that they're qualified to do it and would be more likely to do a good job.
And one of the things, and another question too, Toby, is that CMS did propose to change the facility assessment to biannually. Right now it's required annually in the regulations, and in the proposed rules they did propose to change it to every other year. That is something that we have all opposed, and those new rules have not been released yet. So currently the requirement is still annually.
It's like the grievances. It's all part of those rules that the administration is trying to change. Some of the new baseline care plan. The new good things that were done in the 2016 regulations, they're pulling back. That's a good point. Thank you. I mean, we can't comment any more on that, but for now, it's annual. And I think the revision, it doesn't have a timeline. If they're taking on new people at any time, even if they had a biennial requirement for facility assessment, if the facility took on new residents or wanted to take on new residents, it would have to update the assessment. So we don't want it to be biennial, but I think this requirement would continue, or it could continue. Okay, next slide, please. So, okay, in addition to changes in admission, so we have changes in therapy, we have changes in admissions, we think. We're also concerned about changes to resident assessment. How will assessments change? One possibility is that residents depression will be identified and treated. The trade press, again, this is a skilled nursing facilities article from August last summer. Treating depression could emerge as a PDPM linchpin, both for payments and better outcomes. That article suggests that if a facility identifies and treats depression, it can get $43 more a day, and it would justify, this diagnosis and treatment would justify a longer length of stay. So more money, longer length of stay. The same article also talked about cognitive impairment, $21 a day additional for cognitive impairment being identified. Okay, next slide. Another concern is transfer and discharge. We know facilities have financial incentives not to provide therapy or to provide less therapy, but getting therapy is a major way to qualify for Part A coverage of a stay in a skilled nursing facility under traditional Medicare. If a resident doesn't get therapy 5 days a week, the person may not qualify for a Part A stay unless the person is getting skilled nursing 7 days a week. We're beginning to hear a little bit about facilities giving transfer and discharge notices to residents based on this absence of therapy. But residents are entitled to 2 notices. The notice of Medicare non-coverage, I think it's supposed to be NOMNC, NOMNOC or something crazy notice, so saying that Medicare isn't going to pay anymore. But the nursing home reform law also says that if a resident can be transferred or discharged, the resident has a right to notice and an opportunity for a fair hearing. So these are 2 separate notices that people get. If a facility says you're being discharged from Medicare, which is use of that term discharge, which probably starts getting translated in people's minds as discharge from the facility, realize that there's still a separate notice. Even if Medicare wasn't going to pay, and that was determined by Medicare through the Medicare appeals process, the resident could still stay with another source of payment, like private payment or Medicaid, if the resident had Medicaid. So next slide, please. 4 years ago, I wrote an alert for us. We do these weekly alerts that give you a link later. They're free to come out every week, whatever we think is interesting or important in Medicare. It's about discharge from a skilled nursing facility. What does it mean and what rights does a resident have? And I went into some detail about these 2 types of notices. So the information in that alert is accurate, but the citation to transfer and discharge rules has now changed because of the 2016 regulation. So this is the correct citation, 483.15C. So you might want to take a look at that if you're hearing about transfer and discharge because the resident is not getting therapy 5 days a week. There's still another discharge, another notice and opportunity for a fair hearing. Next slide, please.
Can you just give
sure.
Very briefly what a fair hearing is? There was a question about.
Well, the nursing home reform law from 1987 says the state has to have a process where a person gets notice and has an opportunity to go in front of an administrative law judge, and the burden is on the facility to prove that one of the permissible reasons under the law for transferring or discharging the resident has been met. So don't need the services we provide, you need more than we provide, you are a danger to yourself or others, non-payment of the bill, or the facility is closing. So just because Medicare is not paying doesn't mean there's non-payment. That means Medicare is not paying. So they'd have to show one of those reasons, and it's an informal hearing. Person could be represented maybe by the ombudsman, by legal services, by family. Resident could represent himself or herself, but it's an independent decision, and the burden is on the facility to show that one of the permissible reasons under the federal law has been met, and the resident has to leave the facility. And if that happens, then the resident, then they have to have a discharge and have a discharge planning process that the person is safely discharged someplace else. They can't just say, you're out of here today, although they do. Right. So, okay, that's, okay. Okay, next, okay, interrupted stay policy. Okay, so this is something that Dara Valanajad in our office came up with, and I think it's something to be concerned about. This is a policy under the PDPM that says if a resident is just discharged from a skilled nursing facility and comes back to the same facility within 3 days or less after the discharge, then Medicare coverage and payment will resume from the day of discharge. So if the person has been there 10 days, leaves for 2, and either to the hospital or goes home or someplace, but comes back in 2 days, then the person would resume coverage with day 11 and be on the same reimbursement system, the same amount of money from that original 5-day assessment. But if the resident is readmitted to the same facility after 3 days, so say day 5, or to a different facility at any point, goes from one facility to another, then there's a whole new assessment and the whole reimbursement clock starts all over again. He raised the concern that this is an incentive to have somebody gone for more than 3 days, bring them back, and start all over again. It's the interrupted stay policy. So that may lead to some discharges for purposes of reimbursement. It's not clear, but it's something just to be aware of. Next slide, please. So another concern we have about PDPM is nursing. Under the theory, of course, there should be more reimbursement for nursing because the focus is supposed to be resident acuity. So you would think, okay, we're going to get more nurse staffing. This is going to be good. And staffing documentation is absolutely critical to getting high rates. That 5-day assessment is the only assessment that's done. The nurses are going to have to be there to do it. So we wondered, will staffing increase? Will staffing increase on weekends? Because that's when there are a lot of admissions that are occurring. We know hospitals like to discharge people Friday. So will there be a nurse there on the weekend? We know from the staffing data from PBJ that facilities many facilities do not have sufficient staffing on weekends. So I was wondering, would this new PDPM lead to better staffing on weekends? But then would the registered nurses be assigned either solely or primarily to doing the assessments? So would they really not be providing care at all? Not clear. Next slide, please. So as I said, the RUG component, the old reimbursement system, covered nursing, but it also included drugs. When they did PDPM, only 57% of the RUG nursing component was devoted to nursing. 43% of it goes to drugs. So I'm not even clear that sufficient reimbursement is even recognized in PDPM for nursing at all, let alone what the nurses are going to do. So nurse staffing is troubling because obviously that's a critical need for care for people, having sufficient numbers of qualified professional nurses, and we know, there aren't enough registered nurses in nursing homes. So PDPM may encourage some more registered nurses, but maybe not. It's not clear. Okay, next slide, please. I think there are other concerns about gaming of reimbursement under PDPM. As I said, it only uses the 5-day assessment. That's the 1-day assessment, and after that, there's the variable automatic decline, decrease in reimbursement for those 3 components: physical therapy, occupational therapy, and drugs. So RUGS did additional assessments on days 14, 30, 60, and 90, but PDPM said, we're getting rid of the paperwork burden and only have that 5-day assessment. A lot of the False Claims Act cases talked about facilities during the assessment period increasing the therapy, and then like for the next 30 days where that rate occurred, like from day 30 to 60, they didn't provide enough therapy to even meet that category, but they were paid on it because they were paid that higher rate because during the assessment period, they had to provide or bill for a high amount of therapy to justify the next 30 days. PDPM has only 1 5-day assessment. After that, it goes down automatically. So I think there's a real serious concern about the possibility of gaming the assessment information. Again, there's that interim payment assessment, which is another opportunity to do a little gaming by saying, oh, this resident is so different, we've got to do a whole new assessment now and start all over again, start the clock running. So that's a concern. Next slide, please. So what's happened so far with PDPM? Other implications. Okay, CMS anticipates that the length of stay is going to be shorter. As I said before, RUGS was 20 days because large copayments began on day 21. But that's, CMS is anticipating a shorter length of stay under PDPM, 15 days or fewer. So if Medicare doesn't pay, then what happens? Well, some residents are going to leave. They're going to leave the skilled nursing facility because they don't have a source of payment. If they're eligible, they might stay on Medicaid. If they stay and are not eligible for Medicaid, they might pay out of pocket. I mean, they'd have to. They've got to pay privately. Those are the only ways we basically have to pay for nursing home care, Medicare, Medicaid out of pocket. There's very, very little private insurance, very little private long-term care insurance. If they're paying out of pocket, then they're probably going to become Medicaid eligible sooner than if Medicare had continued paying for a longer period of time. So just sort of playing out what's going to happen with PDPM as time goes on, I think people are going to just, go on Medicaid more quickly because that's the only way they're going to be able to pay for their stay. Pay out of pocket, become Medicaid eligible, go on Medicaid. Next slide, please. So what's happened so far with PDM? Well, as I said, therapists were laid off across the country, and even speech therapists. The Speech Language Pathology Association said their members are being laid off, although their case mix category does not decline after any period of time. It stays the same. But anyway, therapists have been laid off across the country, and we have not seen any evidence of facilities hiring additional nurses in the first 6 weeks. Zimmett Healthcare Services Group, again in that mid-November analysis of what was happening, said skilled nursing facilities had made $52 more per day under PDPM than under RUGS. They said that was somewhat artificially inflated because facilities got to do new assessments on October 1st. But even without that artificial inflation, they said facilities were getting about $26 more per day. So they were doing quite well. I always, if we were in person, I would ask what people thought was the daily rate for Medicare. How much do they think Medicare is paying? I think they probably think about the Medicaid rate, $200 a day. According to a report I was reading earlier this week, the average SNF reimbursement under Medicare Part A was over $500 a day. That's average. And when I looked at the top rate for 2020, it's over $900 a day. So facilities are making an enormous amount of money on traditional Medicare. That is their highest payer. It's why they really want Medicare, traditional Medicare. After that comes Medicare Advantage, considerably lower. And the same report that said that they're making over $500 a day said the profit is on average $100 a day. On average, $100 a day for Medicare. So it's Medicare, Medicare Advantage, private pay, and Medicaid. That's the hierarchy of payment from highest to lowest, although Medicaid rates are going up all over the country quite dramatically. So next slide, please. I think some of the industry analysts are very concerned that CMS will see this as not been budget neutral. Some of them are saying, my God, it's obvious that didn't happen. It's not a budget neutral system. And they're predicting that CMS will recalibrate the rates to reduce the large increases in per day payments. American Healthcare Association is saying, well, it's too soon to say that. Things are going to settle down. I don't think CMS will really change the rates. They're trying to tamp down the concern among their members, but it's clearly not budget neutral, and facilities are making a lot of money under PDPM. Next slide, please. So I think just in summary, what I would say about PDPM is that it really does make an enormous change in the financial incentives for facilities, and facilities are changing what they do to maximize their profits, to take people that will give them higher rates, cutting services if they're not getting paid for the therapy anymore. Even at one of the technical expert panel meetings, the representative from MedPAC, Carol Carter, who is like the Medicare person over there at the Medicare Payment Advisory Commission, said this industry will follow the money, and if there are different practices, that's what they're going to do, and we're seeing it already. Cutting therapy, taking in people that will bring in more money. So I think we have a lot of concern about how this is going to work for residents, certainly therapy, admissions, assessment, transfer, discharge, staffing, and other gaming. And we need to be aware of what's going on, monitor it carefully, and do as much advocacy as we possibly can to make sure residents are getting the care and services they need to attain and maintain their highest possible function and do as well as they can, have the best quality of life in nursing homes. So next slide, please. This is what the Center for Medicare Advocacy has. We do weekly alerts. I had one of them in the materials. These are free. We have a lot of self-help materials that are for free. So just, get whatever you want from our website. Please go to our website, medicareadvocacy.org. And I also do a monthly newsletter that's available on a subscription basis on nursing home enforcement issues. And next slide, please. That's who I am and where I am. And please stay in touch. And if you're interested in working with us on some kind of request to CMS about the facility assessment issue, just, get in touch with me. I'd like to write some kind of formal request to them to take this seriously and to give information to states, because I think CMS knows that ventilators and are a key change that, if the facilities haven't been doing this before and are doing it now, we want to make sure that they're qualified and capable to do a good job for people. It's not saying they can't, it's just saying we want to make sure it's okay. So anyway, if you're interested in that, please let me know. And if there are any other questions, I'd be happy to do my best to answer them. Thank you, Lori.
Thank you, Toby. Lots of things to consider, and I think that you took a very difficult topic and made it understandable for many of us, because the payment issues are certainly complex, and clearly the PDPM system has made it even more complex. We're going to take a few minutes for questions. A number of them have come in, so we'll take a few. So first of all, you mentioned the assessment, and there were a number of assessments around there. So people that are interested in working with you on it, or even in terms of, as you're seeing the effects of PDPM go into effect, we at Consumer Voice and Toby at the Center for Medicare Advocacy are interested in hearing what the impact really is on residents. And so you see Toby's information right there, and you can contact her, you can contact us at Consumer Voice so that, you know, we can get a sense of what's happening. But the assessment piece is really important, particularly because it's not really determined, you know, how public that's going to be and who has access to it. Right now, you know, we don't think that consumers, residents, family members have access, nor ombudsman, right? I mean, we don't, there's no real guidance on that.
It's silent. I think it's silent on that point. It just the state operations manual says they encourage, they're not requiring, but they're encouraging facilities to consult with the families and the resident council, but they're not requiring it. And it doesn't say anything about ombudsman either.
Right, so certainly ombudsman and residents and families should be asking about it, asking the facilities about it, and particularly if you're seeing that new residents with different levels of care, such as ventilators, if there's a new wing like that opening up, or dialysis, or something like that, you know, be asking questions about that. So another question that had come in was that CMS indicated that they were going to monitor individuals' practices regarding therapy. Do you know anything about that? Are you aware of how or when that's going to be implemented, that CMS is going to be monitoring the therapy practices? I
haven't seen anything about it. They just added that information to the assessment on discharge. So they are requiring facilities to say how many minutes. They're going to have to keep track of that anyway for the discharge assessment and what type of therapy. But what they're doing with that, I haven't seen anything out of CMS.
So certainly, you know, as ombudsman, if you're seeing residents that are having big changes to the therapy that they're receiving, if they're not receiving the therapy, if it's suddenly a switch to the group therapy from individual therapy, there are questions that can be asked related to the assessment, the care planning, how they came to the determinations about that, and so that's, you know, clearly an area that can be focused on. So just a clarification piece that you mentioned at the very beginning, this applies to traditional Medicare.
Yes.
And so has Medicare Advantage been affected at all by this? Do you know, or no?
No.
Whatever system that they've used.
They do whatever they do, yeah. It's not affected. Now, some Medicaid programs, some state Medicaid programs have used rugs. Whether they're going to switch now, too, because Medicare has changed, that's unknown. That's up to the states, of course, but they might.
And the same thing with managed care. I mean, right now, that hasn't changed, but they could make changes based on this as well, depending on how they determine that comes in. So one person asked if we're seeing at all whether facilities are choosing to discriminate against individuals needing therapy in terms of accepting them for admission. Have you seen or heard anything about that at this point?
I haven't heard that. I mean, that's, you know, partly why I think people need to be try to understand PDPM a little bit. That's all we can do. It's so complicated, but to be looking to try to figure out if that's what's going on. I mean, facilities have a right not to admit people that they don't want to admit. You know, they do that all the time. They can't do it for an illegal reason, but they can do it for no reason or a reason that they're not saying. So they may be denying people who need a lot of therapy. But we haven't heard.
Yeah.
We just don't know.
Yeah, we don't know that yet. So the regs and the preamble specifically talk about CMS's preference for individual therapy for individuals. But do they talk at all about what an acceptable reason might be to put someone into group therapy? Do you recall?
No, they don't say anything like that. They just say, we think most therapy should be individual, group therapy and concurrent should be an adjunct, and we would expect the facility to explain in the care plan why this is appropriate, but they're not saying what they think is appropriate. They're just saying it's up to the facility to explain why group therapy is appropriate as an adjunct for this particular resident, you know, for this reason.
Mm-hmm. Absolutely. So we're talking today about PDPM and how that's affecting skilled nursing facilities, but PDPM is going into effect for home health as well. Yeah. And so as we're looking potentially at people being discharged possibly sooner from nursing homes because of the change in rules with respect to how much therapy they're getting. That doesn't necessarily mean they're going to get it at home either, if they continue to need therapy, or if they're going home, they might not get the therapy that they're getting now once the new PDPM rules go into effect there.
They went into effect January 1st. Okay. It's groupings. It's patient-driven groupings, I'm not sure what the M stands for, and the people who focus on home care in our program have heard from a lot of people in home health that they're just being denied services. It's a very different system. It also cuts therapy. There's going to be a whole lot less therapy. And even though I think it's 1980, Congress eliminated the requirement that people be in the hospital before they get home care. That's been gone for a long time. The new reimbursement system, PDGM, pays home health agencies higher rates if people are coming out of the hospital. So it's doing the same thing. It's sort of putting into the reimbursement system something that Congress said was not necessary. It's very troubling. We don't know where people are going to get therapy. If they're not going to get it in the nursing home, they're not going to get it in home health. Where are people going to get the services they need? It's very frightening.
And clearly what we know is that the therapy is necessary to maintain functionality. And so, that certainly is going to impact a person's ability to maintain their level of function.
Yeah. When we went back to court in JMO, what I was doing as my part of the case was getting a lot of declarations from individuals, because I talked to a lot of people around the country. And I remember talking to a man. I talked to him quite a bit, but when I was writing a declaration, of course, I had to learn a lot more to do it. This man has MS, and he was living at home, and his wife went to work, and the kids were grown and out of the house. He told me 1 hour of physical therapy 1 week and 1 hour of occupational therapy the next week. So 1 hour of therapy a week. And when he had therapy, he was able to use his computer, answer the door, answer the telephone, use his wheelchair. When they took the therapy away, which happened from various home care agencies, he was completely dependent. He could not do anything. And I realized we're talking about almost nothing. 1 hour of therapy a week that makes the difference in this man's life from having a life or being completely dependent. And when the judge ordered, had the new order and said what CMS had to do, I wrote to the people that I had gotten I'd worked on with declarations, and he wrote back and said he had a new home care agency that gave him 1 hour of PT and 1 hour of OT in the same week. And he said, my body felt so different. And I just about wanted to cry. We're not talking about a lot of service to keep people, functioning and having a life. That's what we want to do. And we know that when they do that, people, if you spend more on home care, there's less hospitalization. I mean, we know that from home care people, from our JMO council. So it's very troubling to think of these therapy services being cut for people.
Absolutely.
Really terrible.
So several people have been commenting about the lack of therapy, or that people are being discharged pretty quickly around the 2-week mark.
Okay.
And so there's questions related to appealing determinations of Medicare coverage of the therapy. And do you have any recommendations for information they can be providing to the hearing officers when they're appealing the Medicare determination of coverage to kind of help their case that they should continue to get the therapy? Yeah,
well, I mean, we have self-help materials about that exact issue. So people should go to our website and look for that, MedicareAdvocacy.org. That could be useful. I think what we say to people in those situations is try to have a physician support why the person needs therapy, what's the purpose, not just I'm as a doctor, I'm ordering it, but what specifically the person needs and why. So we have examples of letters that physicians have written. We have a template that a private attorney wrote that helps the physician fill in the blank, or sometimes the family will try to draft it and then the doctor might change. But the basic point is that I'm the doctor, this is my patient, this is the medical condition, this is what my client needs. So the client needs, physical therapy to be able to move from the wheelchair, from the, bed to the wheelchair, wheelchair to the toilet, so that she can go back to her assisted living. And why this person is a good candidate for physical therapy. So one letter I'm thinking of that a daughter got, which is what started me thinking about these doctor's letters. The last part for that person was a very short letter, like half a page, but it persuaded the nursing home. They told the daughter, we'll give your mother 30 more days of therapy. So I was ecstatic. She was ecstatic, and she sent it to me, and we redacted it. But the last part, so besides who I am, I'm the doctor, this is what she needs specifically and why. The last thing is she's a very good candidate for therapy because she had been in a car accident and had physical therapy. She responded very quickly. She's very motivated, whatever. Sometimes the families can write. We have a very excellent letter that a family member wrote that was successful that said, the families are there all the time. I mean, to the extent if they are all able to be there. I saw my mother needed this. The order said 30 minutes. They gave her 5 minutes. They weren't doing what they said. They were already cutting her off before she even started. Or the family saying, this is how much she advanced. I saw the change. Families can write what they know. You can get a doctor's letter. There are different things to do, but we do have good information, good self-help materials that can help people, and I'd be happy to send the template to anybody who's interested.
Sure. And so again, that's that's MedicareAdvocacy.org, where you can get that information. And one of the
it's a prior slide has the link to it. Yeah.
Right. And one of the earlier slides, Toby mentioned, some of the things that were available on that page on the site. So last question that we'll do for today is, are you hearing anything about changes in therapy occurring by specialty? So, for example, limiting speech therapy while continuing to push occupational therapy. Are you seeing changes within the therapies or just broadly at this point?
We haven't heard about specifics in therapies, but really the speech you would think, because it doesn't decline in rate, would not be cut. But we haven't heard anything specifically about changes in one therapy as opposed to another. But all the therapy associations, all three of them, have said their members have lost jobs all over.
Yeah, they're really concerned about it.
They're very concerned. They're very concerned.
So clearly there are a lot of questions about this, and as it's, in the early days of implementation, we're just a few months into it at this point, we're still determining what the effects are. So as we mentioned earlier, we do want to hear from you all about what you're seeing with respect to the implementation, what's the effect on residents, and what are the changes being implemented based on that. So with that, Toby, thank you so much.
Thank you.
I'm sure we'll touch on this topic again in the future. And thanks to all of you for joining today. As a reminder, the recording and the slides will be available along with links to Toby's website, where you can get more information about this. Thanks for joining us this afternoon. Have a good rest of the day.
Thank you.